The next case is a 42-year-old female who presents with a history of alcohol abuse. She's been clean and sober for 7 years, has chronic neck pain, and is taking hydrocodone 10 with acetaminophen daily for her pain. She requests early refills frequently, and you do a urine drug test on her. It shows hydrocodone, hydromorphone, and a cannabinoid. This will be an easy case. What do you do with that?
An easy case, especially with the recent election. You have prescription marijuana, medical marijuana, and you even have a couple states who approve recreational marijuana. Easy, no. Common, yes. What I do in this situation, obviously this patient has risk factors, has a history of addiction, has a history of misuse of medicines with early refills. So this is a high-risk patient. Before you take care of this patient, you have to ask yourself, do I have the education and comfort level to take care of this patient? Do I have the resources to take care of this patient? If I don't, then I'm going to refer it to one of my colleagues.
In your experience, is this something a primary care doc could do?
No, we wrote a paper called Universal Precautions, and this is either be a group 2 or group 3 patient, and that a specialist should come in to help you either co-manage the patient or take over the patient. Let's take all these variables out of the picture and just talk about marijuana in the urine drug test. And the patient comes and says, "Doc, it helps me with my sleep, it helps me with my anxiety, it helps me with my pain."
And I've got a medical marijuana card, so it is legal now in my state to use it.
Exactly, whatever. I say, I agree with everything you say. I agree with everything you say, but in my practice, I prefer and do not want my patients to use marijuana with the medications that I prescribe, because I don't know the controlled substances I prescribe, including opioids. I don't know the drug-drug interaction with marijuana. I don't know whether the drug that I'm prescribing will be part of the problem or part of the solution to you with marijuana. I don't know whether marijuana and the drugs I'm prescribing will affect your cognitive ability. And if you get into a car accident, then I may be at risk in this area. So you have to make a choice. It's your choice, and I'll back you up 100%. If you want to keep on taking marijuana in whatever form that you're taking it, go ahead, do it. But I am not going to prescribe this particular molecule to you. I will take care of you in the other areas of your health care. I will help you with your pain exclusive of opioid medications, but it's your choice. Either the opioid medications or the marijuana, it's your choice.
I concur 100% of what Howard said. I'm going to take it one step further, actually. The patient, according to our agreement, thank God our state still no medical marijuana, but let's say we're in a state of medical marijuana. And according to the patient agreement, opioid agreement that we have, that all his medications should be prescribed by one physician. And if the patient chooses to treat themselves, or they choose to go to someone who writes their medical marijuana, that's, in my opinion, violation of their opioid agreement, because now they're taking 2 medications for the same disease from 2 different physicians, and they have to choose. If they choose to stay with my practice, I'll be gladly continue their medication without the medical marijuana. If they choose to stay on the medical marijuana, they'll be gladly to go to the other physician and let him or her take care of their medication. But you cannot take 2 different prescriptions for the same disease from 2 different physicians. And this is, in my opinion, a very easy way out from a very common and complicated problem that we're coming into right now. And in my opinion, as Howard said, it's going to get more and more, and more states going to jump on the wagon for the medical marijuana.
The other point to make, if the patient agrees with you and decides not to take the marijuana in the future, and you're going to test her with urine drug tests, you have to know that urine drug testing will be positive for quite a period of time with marijuana, because marijuana is lipophilic. And depending upon the grade of marijuana she is smoking, the frequency she's smoking, the urine test could be positive for greater than a month time. So you have to be aware of that if you're going to follow that patient with testing.
Bill, this is a situation that is analogous to a patient who shows up with a benzodiazepine that has been prescribed by another physician, who makes the point to you that it helps them in so many different ways. It's a legal medicine, it's prescribed by a physician, and therefore, what's the problem? Why do you have a problem with this? And in fact, I think that, as others have already said, the problem really gets back to, aren't there alternative, more traditional better treatments for you that could address whatever reason it is that you're taking the marijuana.
The insomnia, the anxiety, whatever the marijuana is doing, the nausea, we have better treatments rather than using another addicting substance that you don't have control over.
Exactly. And I think that it's important to say to them, there are these other issues that I'm concerned about, but the primary issue is really that your treatment is not optimal. If you're using this for these reasons, I know that there are better treatments. I understand the risks and consequences, some unintended, of the treatment you're taking, and therefore we have to take your care to the next level. You can decide not to participate. You can say you don't agree with me. But then you're rejecting me and you're rejecting my treatment recommendations. I'm not rejecting you. I'm not neglecting you. It's quite the opposite.
So let me just give you a different, you are all in pain practices. You typically would be seeing patients that have already cycled through primary care and felt to be not applicable because they are more difficult to treat in primary care. So you have somebody in our setting where we have felt that the risk isn't too bad, not this particular patient. I'm just trying to get a sense about marijuana. Would you say that would go across the board for everybody, even low risk patients who occasionally use marijuana? You wouldn't recommend it at all?
I wouldn't recommend it at all because it muddies the situation. The patient has to make a decision. Right. You as a prescriber have to make a prescription. Under federal regulations, you're not obligated to prescribe under demand. You only prescribe when you think it is clinically appropriate. And you're making a decision that's best for you, your practice, your family, and your community. We don't know the interaction of marijuana and opioids as far as driving ability, for example. And if that person gets into an accident and gets tested and positive for marijuana, and then you come back, why did you keep on prescribing this medicine when you knew that they were on this particular
It's
drug,
a risk.
this risk to marijuana?
Yeah.
Again, you become part of the problem rather than the solution.
I don't believe this has anything to do with low risk, moderate risk, or high risk. It's just the concept itself. This is the all or none phenomena.
Right.
It's
your
yes
practice,
or
you get to do what you want to do.
Exactly
That's
right.
why it's called
yes
your practice.
Or no. And I believe that those patients do consume a lot of time from primary care physician, and I strongly advocate for sending them, as Howard said, to a more specialist, because if you believe that you are spending too much time on one particular aspect of a healthcare for a patient, then it's time for you to send them to a specialist.
You know, it's interesting. You bring up an important point as far as the primary care doctor. It takes a second to say yes, and it takes 30 minutes to say no. And a lot of doctors take the quick way out, and that's wrong. And if you don't have the time, then refer the patient.
Yeah, and you know, we're getting better with antibiotics because it's a lot easier to give an antibiotic than to explain that it's a virus and it's not going to get better. And we should do the same thing with our opioid prescribing, is have these rules that really are in place for a good reason. I want to also point out in this patient, she's at a risk group because of her age. She has that alcohol history, and she's been calling in for early refills, which has a whole differential diagnosis of why is that? Are we undermanaging her pain? Is this a personality disorder that is...
well, let me give you another one. Let's say that you're prescribing, let me make up a number, 100 pills per month. Maybe she's selling 50 and keeping 50 for herself in order to pay for the marijuana. Marijuana is getting more expensive nowadays.
So this is a risky population, and then adding a cannabinoid on top of this that you've discovered with the urine test appropriately, and you're glad that you actually discovered that. Now it puts you in a context that you have to look at this patient differently. You have to start doing things related to her early refills and her history of addiction to alcohol. You have to do things that you discovered on the urine. So that's a good thing. It complicates it, but that's why you need to get help with the patient.
Absolutely.
But I think having a rule about the marijuana is important. I want to thank the panel for helping us with this discussion today, and thank you.